Hi everyone, my name is Allison Beatty and I'm presenting on the assessment of outcomes achieved in orthopedic trauma acute care using the AMPAC 6-clicks assessment. I provided acute care physical therapy for patients on the orthopedic trauma floor in a large urban hospital in Central Florida. At this hospital, my instructor and I saw about 9 to 10 patients per day, and our sessions were usually 25 to 30 minutes long. Due to the nature of the setting, we often co-treated with physical therapy assistants and occupational therapists for both initial evaluations and follow-up sessions. For this research project, I followed the progress of 16 patients ages 26 to 72 with various injuries, surgical interventions, and comorbidities. 13 of the patients were male and 3 were female, and the average comorbidity index was 2. Some of the causes of injuries were motor vehicle accidents, including motorcyclists, falls, sporting event injuries, lawnmower accidents, and pedestrians struck by vehicles. Of the 16 patients, 9 had single joint or single extremity diagnoses, and 5 had multi-joint or multi-extremity diagnoses. Some of the common diagnoses were tibia, fibula, ORIF, IM nail of the femur, and pelvic fractures requiring external fixation. I also collected data for 2 non-orthopedic patients due to overflow at the hospital. The diagnoses for these patients were gout and post-stroke. To monitor the progress of these 16 patients, I utilized the AMPAC outcome measure for each initial evaluation and follow-up session, and the initial scores ranged from 6 to 18. Each of the 16 patients was first seen for an initial evaluation and then either 1 or 2 follow-up sessions, depending on the length of stay. During the initial evaluation, bed mobility and transfers were assessed for level of assistance required. Patients were educated about their post-surgical precautions and were instructed on how to use an assistive device to maintain these precautions during transfers and during ambulation. Strength and range of motion were screened for each patient unless specific post-surgical precautions did not allow for this. Patients were given 2 to 3 exercises to perform daily, including general range of motion and strengthening exercises. Follow-up sessions targeted deficits in functional mobility determined during the initial evaluation. The length of stay varied greatly for this setting, but the average number of visits before discharge was between 2 and 4 visits. Some patients were seen twice in a given day as well. The bar graph shows the AMPAC scores for each patient over their 2 or 3 visits. According to the literature, the minimal detectable change, or MDC, for the AMPAC outcome at the 90% confidence interval is 4.72 for basic mobility. The proportion of patients who made measurable change based on the MDC was 1 out of 16 in 2 visits and 1 out of 8 in 3 visits. The outcome results are overall lower compared to the University of Florida Doctorate of Physical Therapy class benchmark. Of the data collected, 2 out of 16 patients met the benchmark for visit 2, and 2 out of 8 met the benchmark for visit 3. One reason that the scores are lower than the benchmark may be that 6 out of 16 patients completed visits 1 and 2 on the same day, visit 1 in the morning and visit 2 in the afternoon. It may not be likely to see the benchmark MDC in only a few hours' time. Due to the nature of this setting, it was challenging to collect outcomes for 16 different patients for 3 different sessions because the hospital utilized physical therapy assistants for most follow-up sessions, and physical therapists perform many initial evaluations each day. One of the main goals of physical therapy in this setting was to assess patient safety and preparedness to return home. If patients were unsafe to return home at the time of their initial evaluation, the goal was to determine the most appropriate discharge plan and have patients discharged as soon as possible, making it difficult to track progress over time. The hospital required that the AMPAC assessment be completed for every patient encounter, which made it easy to access in the documentation system. This was a major facilitator of the data collection. Although my setting and patient population made tracking progress over time difficult, this experience has helped me understand the importance of setting aside time to devote to quality improvement analysis as a future clinician. I'll continue to utilize the recommended evidence-based outcomes and follow the research to determine which outcome measures are most appropriate for the patient populations I'll treat in the future. Thank you for your attention. I hope you enjoyed my presentation, and please let me know if you have any questions. Thank you.